So today's webinar is presented by Dr. Stampas and by Dr. Triadafilopoulos. And by way of some background, they're going to speak about objective assessment in neurogenic bowel. Obviously, we know neurogenic bowel is a huge issue for our patients. It's a big part of the care that we deliver to our patients. But unlike other systems in spinal cord injury, we rarely measure it objectively. So when you think about it, we do urodynamics for bladder management, we measure blood pressure when our patients are getting dysreflexic, we do pulmonary function tests for respiratory function, but in our day-to-day practice, we rarely measure bowel function objectively. So it's wonderful today to have Dr. Stampas and Dr. Triadafilopoulos presenting to us on how we might consider measuring neurogenic bowel function objectively amongst our patient population. So over to you, Dr. Stampas.
All right. Thanks, Dr. Smith. I appreciate the introduction. Can you hear me okay?
Perfectly. Thanks.
All right, great. So I'm going to load up some PowerPoints because that's what we do. Give me just a sec here.
While you're doing that, I might just remind everybody about the question and answers, which I forgot. So you can type any questions in the chat box, and then at the end of the presentations, I will moderate and we can have a discussion. And if there's any particular questions that we don't get to, you can email the Asia office and they will be directed to our presenters.
Okay. All right. So are you guys seeing the screen? Perfect. So like we mentioned, we're going to be talking about the objective measures of neurogenic bowel function. Dr. Triadafilopoulos hopefully will be joining us. He is a GI specialist neurogastroenterologist, which is pretty hard to find across the street from us here in Houston at MD Anderson. We're both Greek, and that's totally a coincidence. Okay, so the content's going to be talking about the status quo of our management of neurogenic bowel, both early spinal cord injury and more chronic, then the objective measures, and then the future research directions. So I'm hoping that part of this presentation will inspire people to kind of look into measuring the function of the neurogenic bowel, taking it beyond subjective reporting from our patients. So in early spinal cord injury, so inpatient rehab, essentially, we don't have a ton of guidance. So I pulled through the PVA guidelines from 2020, which looked at literature through 2018. And the things that they recommend, I've kind of highlighted it. And of course, it gets into more detail in the guidelines, but essentially, early in spinal cord injury, during inpatient rehab, we're pushing for a bowel movement every day. The reason for this is to establish a predictable routine, prevent constipation, prevent fecal impaction, prevent ileus, and reduce incontinence and complications. Ideally, you're doing this after meals to take advantage of the gastrocolic reflex, and it should be complete within 30 to 60 minutes. There's broadly two types of bowels. After spinal cord injury, you have your reflexive type. That's an upper motor neuron bowel, where you can use digital rectal stimulation, rectal stimulants to have the rectum contract and evacuate the bowels. And then you have an areflexive bowel, which is lower motor neuron, does not have the ability for the rectum to contract and evacuate the bowels. So you have to use manual evacuation. I'm putting that there because for the most part, the vast majority of patients do have an upper motor neuron bowel. So we're going to be mostly focused on this kind of reflexive bowel program, okay? So in general, the goals of this bowel program, again, taken from the guidelines, to have a regular bowel movement at least 3 times per week, to have complete rectal emptying, minimal incontinence, predictable timing, and efficient bowel care, less than an hour. So what does this look like in practice? So I've trained in several facilities. I've worked in a couple of different facilities, and I don't have evidence to support this, but for the most part, this is what everybody is doing for spinal cord injury rehab, at least in the Northeast and in the South in the US. Our patients early in spinal cord injury are put into bed lying on their left side. Nurses are then administering a bisacodyl suppository every night, along with digital stimulation nightly. And the medications that patients are taking daily include docusate sodium and senna. And they're kind of timed to kind of work most effectively. As far as evidence to support this, there really isn't. It's just kind of what we've done for many, many, many years, right? Um, so the approach has good rationale, right? So I look at bowel meds and I put them into kind of categories, right? Like soften it would be your docusate. Push it would be your stimulants like senna and bisacodyl. Um, you have pull water in like osmotics like Miralax, polyethylene glycol, lactulose, megcitrate. You have the newer meds which actually turn on secretion like Linzess and Amitiza. And then there's fiber, which we could talk about it, but it should be used cautiously. It adds bulk. It um, it can kind of slow things down if your transit time is slow. So um, the approach has rationale, but it's really not evidence-based. And so I wanted to then kind of give us like a broad view of what happens early in spinal cord injury. So when someone's injured, they're brought to the trauma center and they get imaging, right? They get CAT scans of the head, of the spine. Maybe they get the MRI there and blood work and urine labs, right? And they're stabilized and then they're sent off to rehabilitation, acute inpatient rehabilitation, where they'll get even more imaging, right? They'll get a chest x-ray, an abdominal x-ray, perhaps a spine x-ray, and then more blood work and more urine labs, right? And then in the US, if you're in a model system, you get even more stuff added to this, more kind of data points to characterize your spinal cord injury. So you'll get the INSCI exam 3 times, right? That's formerly the Asia exam. So you'll get it early on while you're in the trauma center. Let's see if I can use a laser pointer. Okay. So you'll get it early while you're in the trauma center, and then you'll get it on admission to rehab, and then you'll get it on discharge to rehab, right? And essentially that's 60 muscle tests. So you're doing manual motor testing, 60 muscle tests, right? You're doing light touch testing 3 times. That's 168 dermatome tests with a cotton swab. And then you're doing pinprick testing 3 times, and that's 168 dermatomes with a pin. So how much does all this data inform us about the function of the neurogenic bowel, right? Zero, right? None of the stuff that we're collecting will tell us what's going on with the bowels, right? So even from the very beginning of spinal cord injury, we're truly lacking objective measures. So this is kind of what it leads to, right? So this is what we're doing, the status quo of the sideline, digital stimulation, the medications, right? This is done in the hospital setting. Usually a nurse is doing it. We're training patients to do it. And then eventually we're discharging patients home where everything has changed, right? There is no nurse generally doing this. The diet is different. Um, Essentially everything changes, right? The assistance that you have has changed, right? Where perhaps you don't have the help at night, maybe you only have help in the morning to help with the bowel program if you need it. So there's this kind of transition to the subacute and chronic phase of injury. And as clinicians, we're just waiting for the bowel problems to start. And that's largely what we talk about in my clinic. The symptoms that we see is that the timing, it no longer takes 30 minutes to finish your bowel program. It takes over an hour, right? And then the volume that you're getting, it kind of isn't as good as it used to be. And then after maybe several weeks, there'll be a very massive bowel movement. And overall, it just leads to frustration and you're just completely unsatisfied with your bowel program. Um, so then we get to the management. So after the problem's kind of developed already, right, we're kind of chasing our tail. We get into the management where you're throwing medications at them, essentially, like a little kind of ticker tape parade. And generally, patients don't like that. And I suspect it leads to non-compliance. The more meds you prescribe, the less they're going to take them. Um, and it's not like we're, as physicians, we're not getting paid by prescription, right? So we're not really psyched about prescribing all these meds. We're just trying to help, but we're flying blind, right? We really don't have like that objective measure, right? We're only kind of really hearing about this problem when it's like really bad, essentially, for most patients. So that's kind of where I wanted to kind of tackle this issue and just look at what's out there in the literature, because it's certainly not present for clinicians in spinal cord injury, for my fellowship, for the training that we provide for future faculty. We're not pushing any kind of objective measure, and it's not in the guidelines. Um, so what's out there? That's what we wanted to know. So we performed a systematic review. It was pretty expansive. We looked at abstracts that included neurogenic bowel in the mesh terms. So really, really broad rev review of literature. We didn't limit it to spinal cord injury. We wanted it to look at all the populations, and we appreciate that spinal cord injury is a small population. There are other CNS neurogenic bowel populations that are much, much larger than spinal cord injury. So what are they doing, right? That's important to know what's out there. We also included trials and protocols that did not have results, because again, it wasn't really important what they found. We wanted to know how they were measuring it. So after our first kind of look through the literature, we found 153 eligible manuscripts to review. And if you guys have ever done a systematic review, that's like way too much, right? So we chopped that down to the past 10 years. So we published this in 2023. And at the time, we limited it to literature from 2012 to present. And so we ended up with 49 records to review. We use definitions for neurogenic bowel that's out there in the literature, right? Fecal incontinence and/or chronic constipation resulting from a CNS disease or injury. A little controversial, we did include the diabetic population because it's a huge population, and it is probably a good place to maybe find neurogenic bowel objective measures. And you can make the argument that the vagus nerve is part of the central nervous system, which can be affected by diabetes, right? So I did have a rationale. And then we focused on the colon, right? Because generally that's where we see the biggest problem with neurogenic bowel. It's the colon, the large intestine. So if the abstracts mentioned the esophagus, the stomach, and or the small intestine, with no mention of the colon or the entire GI system, we were excluding the kind of upper GI pathology. And then, of course, the abstract had to mention objective measures, right? It had to be mentioned in the abstract. So for more details, please check out the systematic review. We really get into the use cases and their findings. But I just wanted to highlight some of the different things that we found that perhaps could be applicable for spinal cord injury. So colonic transit time, that's going to be a major category to study neurogenic bowel. And it was the biggest or the most studied category that we found in our systematic review. in these reviews, it's consistently abnormal in the spinal cord injury population and the neurogenic bowel dysfunction populations. And you're able to use this measure to differentiate between disease controls, slow versus normal transit, and even response to interventions, right, which I think is huge. The strengths are that it's physiologically meaningful, right, how things are moving through the colon. It's reproducible and you can track changes over time, right? These are all things that I think are meaningful for our population living with spinal cord injury. So the methods they use for this include radiopaque markers, wireless motility capsules, and scintigraphy. And the limitations, and this is going to be an overarching theme for the limitations, is that the objective measures don't often or don't always correlate with the symptoms, right? It's inconsistent. Sometimes they do, sometimes they don't. We can kind of highlight some of the ones that are consistently correlating with symptoms. And then the variability, how people are using these measures is varied in our literature review. All right. So I see George has joined us. Hey, George.
Hi, sorry for being late.
No worries. Um, I'm going to be asking you questions, so I hope you're ready.
Sure, I'm
Okay.
ready.
Okay. So these I have examples of X-rays from two research subjects who I used SITS-mark capsules. Um, these are radiopaque markers, right? The first gentleman has paraplegia. He's older, uh, moves his bowels daily. His bowel program takes 2 hours at least. This is kind of why we enrolled him in this clinical trial. And then we use the neurogenic bowel dysfunction score, which he had 13, which equals moderate dysfunction. And so after ingesting the SITS-mark capsules, 5 days later, you get an abdominal x-ray. So Monday ingestion, Friday x-ray. And you don't see any SITS-mark capsules in this abdominal x-ray. Then my second patient, who was a young person with tetraplegia, who moved his bowels daily as well. He was fine with the time. He'd like it to be a little shorter. His program takes about an hour. And then his score was 14, which, that 1 point difference tips it over to severe dysfunction. And sure enough, 5 days after ingesting the SITS-mark capsules, you could see the remnants of these capsules. And so, question for George, who has more experience in, deciphering what this means. How is something like this kind of scored after ingesting SITS-mark capsules? Like, what would your interpretation be of this X-ray here on the right?
Well, for some reason, I cannot see the X-ray. For some reason, I don't know why, but be it as it may, if it shows rings within the pelvic rim, that suggests that there is a problem with the emptying of the rectum. If the rings are all over the place, all throughout the X-ray, it is a combination of a slow transit constipation, that is, the entire colon is dysfunctioning, and possibly a erectile dysfunction or dysynergia, as we call it. So it is based on this study. We can only say that much. In terms of the severity, we cannot really link it to severity. We just can say is it slow transit versus dysynergia.
So I shared this picture with you a couple weeks ago. If you can recall, there are capsules in the pelvic ring, and then there's also in the descending colon, there's a few capsules as well. So how would that change your impression?
That's the formal interpretation is that there is a component of a slow transit constipation.
Okay, so um, we'll get back to these SITS-mark capsules in a little bit. The next thing that I want to talk about is anorectal manometry. This came up quite a bit in our systematic review. This is more of a mechanism test. I equate it to the equivalent of a urodynamic study for the bladder. It measures sphincter pressures, rectal sensation, dyssynergia, the recto-anal inhibitory reflex, and then balloon expulsion, which is functional output. With it, in the studies, they're able to differentiate an upper motor neuron versus a lower motor neuron bowel. And, I just want to sit there a little bit because it's not always straightforward, right? Like so many people that you would expect to be lower motor neuron bowel, let's say because their injury is at T12 or T11 neurologic level. Again, the INSCI wasn't designed to tell you what the function of the bladder is, right? But in the textbooks and everything, that should be more of a lower motor neuron bowel. So it would be nice to be able to have a study to help distinguish in many cases. You could also identify dyssynergic defecation. The clinical value is that you can use it to help explain why bowel programs fail, and you can use it to guide therapy, meds, and neuromodulation strategy. And I also wanted to give another kind of shout out to the balloon expulsion test. And we're going to have George talk about this in a bit. But it did have the strongest correlations with symptoms for fecal incontinence and constipation. So it was, and that's in spinal cord injury, really strong correlation with symptoms. So George, this is your slide. It's your turn.
Well, unfortunately, for some reason, I can only see a component of the slides, and I don't know why.
Oh no.
I'm trying to minimize or maximize the screen. Nothing happens. So I
Let
can
me
only see the word COM and high resolution manometry. For some reason,
let me try to switch screens because I have it on like my wide screen. Sorry about that. I hope it's not happening to everybody. Okay, let's see. Monitor, we're going to go to that
Certainly not
monitor.
happening for me, Argy. They're perfect from where I am. I can see them very well.
Okay, that's a relief. Okay, so let me go back to the presentation or share, sorry. And we're going to share screen 2. And then we're going to go here. Okay, is that any better, George?
I don't see anything. I see our images, not the sharing of the screen.
Dr. Smith, do you see the screen?
Not right now. I'm seeing you now.
Hit share again.
Okay. Thanks, Carolyn.
Hit share again. Okay, let's see.
We see, there you go. I see a slide.
Which is again magnified, but nevertheless I can read it. So it's better than before.
Okay.
So when we do an anorectal manometry, we're assessing 3 components. The first component is the actual pressure findings, which Arjun just mentioned, which is basically the anal pressure in response to baseline and squeeze efforts, and in response to a push effort. And we also are measuring the rectal pressure, which is above the anal canal, and looks at the synchronization between the rectum generating pressure and the anus relaxing in response to that rectal pressure to allow evacuation. If that synchronization is not taking place, we have something that's called dyssynergia, and that actually creates a significant problem. Sometimes the anal pressures are low and the rectal pressures don't have to be that high, and they're more effective, if you will, because the distal opening is relatively, low pressure profile. But depending on the findings of this study, that is the measurement of the pressures, we can determine the degree and the type of dyssynergia that we encounter. There are people who have a disconnect between the rectal pressures and the anal pressures. That is, when the rectum contracts, the anus contracts as well. And that actually is trying to squeeze toothpaste out of a closed tube. The second component is the rectal sensory test. This is done at the same time in the same context of the anorectal manometry. The rectal sensory test is basically an inflatable balloon that is inflated in a staged fashion, and we're trying to assess the degree of rectal sensitivity. And
George, I think I have a slide. Hold on. This helps? Yeah.
That's the same thing, yeah. There you go. So you see the balloon, it's not like this balloon, but it's a very professional balloon. But be it as it may, we can actually, as you can see here, we can have the first sensation of constant feeling of pressure by the balloon. We have a second stage, which is a defecatory desire volume. That is, the person starts to feel that they need to evacuate. And then there is another level, which is the maximum tolerated volume, which can reach sometimes up to 300-400 cc's of balloon distension before the actual patient feels the balloon inflated in the rectum. So based on that, we can actually assess the rectal sensation. Sometimes that sensation is absent, sometimes is present at different levels, as you heard. And based on that, we can decide what we're going to do in terms of what the rectum can tolerate. Now, there are patients who may have a very significant degree of hypersensitivity. This usually does not happen in the population with chronic constipation, but it can happen in the patient who has some degree of colitis, which is an inflammatory state of the rectum. And then we have the balloon expulsion, which basically is the ability of the balloon to be expelled by the patient's pushing out. And that is defined as the ability to expel the balloon at 60 seconds of effort. So if the patient is unable to evacuate the balloon inflated at the particular time point, then we know that the ability of the system collectively being able to deliver the goods, if you will, through the anal canal is significantly compromised. And that basically defines a significant degree of constipation that is usually linked to either of the two conditions, but mostly to the defecatory dysfunction. And then finally, as this slide shows, we have the MRI defecography, which is a study that allows us to structurally assess the area of the pelvis and the pelvic floor specifically. And it gives us a perspective as to what's going on structurally. For example, many patients with chronic constipation may develop something that's called rectocele, which means there is a prolapse of the rectum forward towards the vagina, towards the bladder, and also sometimes something that's called rectal intussusception, which means that the rectum and the rectosigmoid kind of fall down and they intussuscept each other. So that's the value of the MR defecography. It is a dynamic study. The patient is on the MRI machine. They have been injected or infused, I should say, with contrast, and the MRI is done in response to the given maneuvers. Based on that structural assessment, we can then decide if there is something that can be done surgically at the level of the pelvic floor, at the level of the rectum. For example, reducing the rectocele or fixating the posterior rectum to the sacrum, which is addressing the rectocele typically, or do a combination maneuver that may involve a gynecologist or a urogynecologist to be involved to help with other abnormalities that are detected either at the level of the bladder, which is the anterior compartment, or the level of the middle compartment, which is the level typically of the urogenital tract, and that specifically applies to women. And the posterior compartment is the rectum with its own issues. So that is a valuable tool in the overall appreciation of the magnitude of the problem. In addition to all this, the MRI allows us to measure the strength and the size, if you will, or the function of the muscles of the pelvic floor and define what we call sarcopenia, which is not very well studied in constipated patients, and I'm not sure if it has been studied in spinal cord patients, but may play a significant role because the weakening of the muscles and the atrophy of the muscles of the pelvic floor contribute to all the other abnormalities that we just talked about and make obviously the prognosis and the degree of response to therapy less likely.
George, this colorful illustration here or graph, this is pressure readings?
This is pressure reading. The red is high pressure. The blue is nothing, no pressure or near zero pressure. And the green is what you expect to see under baseline circumstances. In other words, if you are looking at the anal canal, the green showing you the baseline pressure of the anal canal. When you ask the patient to make an effort to defecate, that green line should go down, should disappear, and no red appear there. And that actually suggests that there is a normal degree of anal relaxation in response to rectal pressure.
So the reading, this is time going along the axis.
This is time along
Okay.
the axis, yes.
Yeah. Okay. Great. Two important things that I just wanted to highlight from what George said, that the anatomy of the rectum and the bladder, they're right next to each other. They're neighbors. So certainly bladder symptoms matter when it comes to bowel symptoms, right? So you can have more bladder incontinence because of constipation, right? And then the sarcopenia, the weakening of the pelvic floor, I think that's something that is also underexplored in our spinal cord injury population. That could also be contributing to what we see clinically as patients live with neurogenic bowel for years. Okay, next we have the all-in-one tool, right? The wireless motility capsules. They can measure gastric emptying, the whole GI, the whole gut transit, right? From the gastric emptying, small bowel, colonic transit, whole gut. Clinically, it can detect global dysmotility patterns, differentiate between colonic delays versus pan-GI dysfunction, and the few studies that have been done in spinal cord injury consistently show prolonged transit in spinal cord injury versus controls. Limitations, and this is under exaggerated, cost, access, and then weak symptom correlation. And George could tell us more about what's out there now with wireless motility.
Okay, well, unfortunately, the wireless motility capsule has been discontinued, which was a huge loss for us involved in neurogastroenterology. What you see here on this slide, you see the actual capsule, which is a little bit bigger than a Tylenol capsule. And what you see in the black is a typical tracing of a wireless motility capsule tracing, which is starting from the extreme left to see the green line is the pH, and it goes down while the capsule is in the stomach. And then as it enters the duodenum, the pH goes up and then stays there. And then there's another drop as the capsule moves into the colon, which is the ileocecal junction here. And you can see here, this is the colonic transit time from here to there. So as a tool, it gives us a panoramic approach to stomach emptying, small bowel emptying, and colonic emptying, all three components measured separately, and overall giving us the whole transit time, which starts here and ends up there. So at the end. There's also temperature monitoring. The temperature monitoring tells us if the capsule is in the body. If it is not, we know that the capsule has passed. And you also see in red, you see the recording of the pressures as they're generated within the gut at different levels. And you can see here before the expulsion, which is almost near the end of the study, you have an intensification, if you will, of the pressures, which is the effort of the rectum and the pelvic floor to expel the capsule finally out of the body. So collectively, those three pieces of information, particularly the pH, give us a very good idea about the presence of any associated dysmotility, either at the level of the stomach or at the level of the small intestine, in conjunction with what we know about the constipated patient with typically some abnormality in the colon. As such, the capsule cannot tell us if there is pelvic floor dyssynergia or incoordination, and that is why it's a test that is used to complement the anorectal manometry. It does not give us a perspective on the sensation, therefore the balloon distension is important based on the anorectal manometry study. So typically, as we evaluate patients with chronic constipation, we can actually use these tools collectively to summarize in our own minds where the main problem is, address that, and then address maybe other secondary issues that may exist. So today, for example, we have a replacement of this test, the wireless motility capsule called the Atmo capsule, which you see here, which is similar in concept as the wireless motility capsule. Unfortunately, has not penetrated the general market yet, if you will, because it was just validated and FDA approved. So we hope that we're going to be able to replace the classic wireless motility capsule with the Atmo capsule to get similar information, particularly as it pertains to the colon transit. Unfortunately, we don't have that at our facility yet. We have ordered it, but it's not something that's going to happen tomorrow. So I don't have personally too much experience with this. I only have experience based on discussions with the company and based on papers that have been published, but there is actually an important piece of information that has been validated against the wireless motility capsule. So we expect to see the Atmo capsule to replace the wireless motility capsule and to hopefully give us the information that we used to get.
All right. Next, we have defecography, which George briefly touched on, which uses MR or fluoroscopy. It's a real-time function test. It measures the pelvic floor coordination, outlet obstruction, structural issues, clinically helpful to visualize the mechanics, the angles, identify dyssynergia, and it was correlated with incontinence in the spinal cord injury population based on the neurogenic bowel dysfunction score. Lots of limitations. It's not well studied. There's difficulty with accessing it. Might not be practical. And it might not reflect real world bowel care, right? You're not on your commode or your toilet. You're in this piece of equipment having a bowel movement in a different position maybe than what you're normally in. Here's a slide that George provided.
Yeah, this is to highlight basically the three components or compartments of the study. The anterior compartment corresponding to the bladder, the middle compartment corresponding to the uterus and the pelvic structures in general, particularly the females, and then the posterior compartment, which actually represents the rectum. And you can see here a little bit of a protrusion forward in the context of a rectocele. Yes,
This
that's
is it, right,
highlight.
George? Yeah.
Yes, yes.
This is my anatomy from med school. So yeah.
Good, good. You went to good medical school, obviously.
Rectum, bladder, uterus, right?
Yes.
All right. Yeah, this one I have a tough time thinking of how we could use it clinically, to use it frequently. I think it would be challenging in our population. But that's why I wanted to also kind of just bring up abdominal X-ray. I want to say that every single physician has access to an abdominal X-ray. I have no proof of that, but I'll put money on it. Every physician in the US has access to an abdominal X-ray. So with that, we can measure stool burden, distribution of stool in the colon, signs of impaction, megacolon. It's available. It's already used, so we use it all the time on our inpatient unit. When we have a new admission from the trauma center, typically they're not focused on the bowels. And so one of the first things we'll do is an abdominal X-ray to evaluate the stool burden. And should it be high stool burden, which it typically is, we'll then do a bowel clean out with strong medications. So this way we can help with our bowel program. It's got limitations, of course. It's not physiologic, poor correlation with symptoms, and it's just a snapshot in time. When I do abdominal X-rays in my outpatients, I instruct them to only get it done after they've had a bowel movement, for example. So I'm really relying on them, doing the right thing, because it will look much different if they have not had a bowel movement. For me, it's essentially useless, right? I want to know what it looks like after they've had what they say is a normal bowel movement. So, in summary, right? We have tools. They are there. We just need to use them. So these objective measures exist. They are physiologically meaningful. They can detect mechanisms at play for the bowel. They can also detect treatment responses, which would be amazing. So, the call to action, like, so what are we going to do? How are we going to do this? And I think a major part is needed. And I always kind of go back to bladder, right? So we know, very little about neurogenic bladder, but we know even less about neurogenic bowel. But the reason why I think we know a little bit more about bladder is because we do combine the subjective patient experience with the objective urodynamic studies. And I think without that objective measure, we wouldn't be as far along with the bladder as we are. And I think that's literally the reason that we don't have a better handle on treatment of neurogenic bowel. Because for the most part, we're guessing as to what to do next with our treatments. So collaboration, I think, with GI is very important. So I was hoping George could briefly tell us what's the landscape in the GI world for people who have, some expertise with neurogenic bowel as a GI physician in the US.
It doesn't look that great. There's a subgroup, if you will, of us that are neurogastroenterologists. As such, they deal with conditions, we're talking about the general population, conditions such as motility disorders, such as esophageal achalasia, gastroparesis, slow transit constipation, pelvic floor dyssynergia, etc., etc. But there are not enough of us to really carry the burden. Furthermore, there are not enough facilities that have the equipment that's necessary for these studies. Specifically, for example, the wireless motility capsule, there were just a few sites. That's why Medtronic gave up. Atmo may have the same problems. The anorectal manometry is expensive to have, so it's a major capital equipment purchase for a particular hospital. So we depend on usually referral centers that are staffed by people who have an interest and an understanding of what is going on in the gut vis-a-vis its motility along the entire length. Usually we spend time in each compartment, if you will, stomach, small bowel, colon, depending on the particular case. A frequent thing that happens is that patients have, although they report constipation, for example, they may have associated gastroparesis. A very common theme these days is patients who are on, let's say, Ozempic, and these people tend to develop constipation and associated slow gastric emptying, which is the main reason they're taking the drug to lose weight. So we're going to see more of these kinds of motility disorders that are reflective of drug use. And also we have the narcotic epidemic that also is associated with both gastroparesis and slow transit constipation. So these are two very, very common themes in the general population. And obviously, I'm sure that they apply to the spinal cord population because many of them may be taking narcotics for pain. That doesn't help. Or they may be taking the agonists that are supposed to be for diabetes or for weight loss, etc. So all of that has to be always questioned. To what degree drugs are used that would potentially harm motility. The general GI population, the general gastroenterologists do not really deal with this. They're not interested. They want to really look at the structure, be it an endoscopy or a colonoscopy or an ERCP, remove polyps, remove stones, whatever. That's not the specialist that will liaison with you in the context of a spinal cord patient population. So unfortunately, the units, spinal cord units around the country will have to identify in their own microcosm, if you will, gastroenterologists who are fitting the bill of a neurogastroenterologist and allow them to participate in the care of their patients as more of a specialized consultation, if you will, either on an inpatient basis or on an outpatient basis. And that is an important component that needs to be carefully thought out regionally according to the available resources. And also the equipment availability, because the number of units that have these pieces of equipment is not enough to really justify this for every hospital in the country.
George, and I don't want to be naive. There are probably GI docs listening to this webinar. I'm curious as to the reimbursement. In your experience, is getting these studies reimbursed through insurance a challenge?
Oh, it has been a significant challenge, and I'm glad you're bringing it up. And one of the reasons that we don't have, if you will, the number of folks involved is because it's an onerous task, if you will. As you can imagine, the consultation is time consuming. The examination of the patient is time consuming. The logistics of organizing all these studies and the interpretation of these studies is actually quite significantly time consuming, and the reimbursement falls behind. To give you a perspective, if I do an ERCP to remove a stone from the bile duct, I collect 7 RVUs for something that may take me usually about 10 minutes. An anorectal manometry will take me at least 20 minutes to read. The nurses usually do the procedure, but it takes me 20 minutes to read, and I get 1 RVU. So, and a colonoscopy is about 2 RVUs, and endoscopy is about 2 plus minus RVUs, depending where you are. So, all of that plays a significant role, and also plays a role in the hospital decision making about getting the equipment, because they see the numbers. That's what they care for, the numbers. It's an unfortunate situation.
George, what about the Sitzmark capsules? I'm using them for research, so I'm buying them. They're costing me $130. What's your experience with prescribing them?
Well, they're not covered by insurance. So,
Oh, they're not.
yeah, no. Same thing we do at MD Anderson, for example. We give the prescription. We have a special pharmacy that we know that they have the capsules, the Sitzmarks, and we refer the patients to that pharmacy, and we send out prescription electronically to that pharmacy. But the patient has to cough up $130. So, and then they have the X-ray, which is basically done at our facility, of course, and there's some kind of a cost there, but that's usually covered by insurance. So, for the Sitzmarks element, again, it's not a favorable situation for many patients who cannot afford $130.
Right.
Okay, well, thank you both. That was a super review of your paper, an excellent summary. We have about 5 minutes left, so I might just give the audience an opportunity to ask some questions. There is one question in the chat box, which is, I guess, somewhat related, but it's, what is your opinion regarding transanal irrigation? And either of you can take that, I guess.
I'm sorry, I didn't hear the question.
What is your opinion regarding transanal irrigation?
Well, Argy, you want to take that?
Yeah, I think it's on the list of ways to evacuate. If it all comes down for me always to like quality of life. It's a patient preference. Um, I, in the U.S., it's an expense. There are devices typically, workers' comp is the only one that seems to be paying for some of these devices. They have a lot of parts, but I'm open to, versus an enema versus suppository digistim, whatever works best for somebody.
Okay, and there's another question similar. NMEs is often not covered by insurance. What is your recommended bowel regimen?
Generic biscotal suppository is fine, but we have many patients who just buy it off of Amazon, and they seem to find it even cheaper than their copay would be at the pharmacy. So I would say look around, use goodrx.com as well. You might be able to find it cheaper somewhere.
Okay, thank you. So then there is a question here. You mentioned that you may refer to pelvic floor rehab. Can you talk more about how you identify and recommend this?
The pelvic floor rehab is theoretically and ideally based on the findings of the collective assessment. That is the anorectal manometry, the rectal sensation, the balloon expulsion, the difficography and the sarcopenia component to it. So, as you know, the pelvic floor physical therapy is at least 6 sessions long in duration. It involves transportation logistics and logistics of geography. For example, not every place has a pelvic floor unit, so that's an issue. So if it is structured properly, and actually that brings up the issue when you're trying to combine services like GI, urology, spinal cord, etc., you should involve pelvic floor in the process, because there are going to be some patients who would definitely gain from that. So based on the science, based on the intelligence that we collect, based on the studies, then appropriate interventions can take place by the physical therapists who specialize in pelvic floor. For example, a very simple thing that we see a lot in diabetics who lose the sensation very easily and they become constipated, and because of diabetic neuropathy. If you increase the bulk by using fiber preparations, you may actually have a recovery of the poor rectal sensation as assessed by the balloon. And that is a very simple step that you don't even need to have very much pelvic floor therapy, although it can be done to enhance the performance of that patient. So there are things that you can do that are relatively easy. Some of them are not as great. The efficacy, if you will, of pelvic floor therapy in the general population with constipation is probably 70% at best. It's not perfect, so but it's worth a try if the right wind is there.
Super. Okay, there's a few more questions here. We might try and fly through them. Any comments on the magic bullet?
Love it. Yeah, it just works faster.
Okay. Opinion on prokinetic agents, and do you use them to increase transit time?
Like the prokinetic, like which meds are those, George? What do you think they're
These are a
referring
variety
to?
of them. They're anything from lubiprostone to linaclotide. Linaclotide is the hottest thing around if you were to look at
Yeah.
the performance, if you will, the market performance. For the right person is the right thing to do. What I see in patients with spinal cord and generally constipated patients is the pushing of the fiber too much. And they get bloated and they get more constipated and they never empty. And there's just a big pain in the behind, literally speaking.
It's a good question here. In the acute hospital setting, is there anything you would like to see nurses advocate for their spinal cord injury patients before acute rehabilitation?
I mean, in a perfect world, it would be developing the bowel program, but we appreciate that they're keeping the people alive, and it's low priority because it's not going to kill them, right, if they don't move their bowels, uh, you know, every day, right? So ideally, they're putting them on the bowel program in the acute setting.
Yeah, okay. And one last question here. There's no literature support for colace, COLACE. Query causes staining and long-term concerns with chronic Senecot use.
There are no concerns, really. I mean, people can use that liberally. The Senecot is obviously the more significant culprit. The colace is harmless. The effectiveness of these things is highly questionable. I think it's more of a placebo. I would spend money on something else.
Okay. Can you give us any recommendations regarding fiber intake for someone with a spinal cord injury?
Yeah, I think fiber has health benefits, but I think you can't overdo it. And if your colonic transit time is already slow, it's just going to slow things up even more.
Mhm.
I typically only recommend it for the lower motor neuron bowels that are liquidy, just to bulk in the stool, so this way you're not having watery accidents.
Okay. 2 minutes past the hour, so I think we'll wrap it up at that. Bye bye, everybody.
Bye. Thank you.
Thank you. Bye-bye.